we said that our venues are not restricted to villages, but in the schools, in the churches, other community spaces. And then we have our influencers, like teachers, parents, leaders from churches and the community. And like sports for boys and girls, and everything led by the RKSK staff, the peer educator, the Ashas, and the ANMs. We have here a few of the snapshots of schools and churches. Here we see the young children are playing some games which are learning games. And then this is the sports quiz. This is adolescent football match that has been held, and the final had just culminated recently. Then the adolescent-friendly health clinics are designed as Friends Corner. You know, in order to attract the young people to these adolescent-friendly clinics, we have called them Friends Corner. And we have a dream that one day these adolescent-friendly health clinics will be the hub where our young people would like to spend their free time. And in these adolescent clinics, we have materials, reading materials in the form of pamphlets, then posters, books which we can lend, and at the same time, we are also providing them with some games that they can play and learn at the same time. Then short films are being screened because we have televisions and video players, and we film some screens, we screen some films, and then it rakes up discussions among the young people. Then we also have, a secluded place where we keep all the contraceptives, the basket of choices, where the young people can just come and pick up whatever choice, method of, that they want, and without the fear of being embarrassed. And in these, we even have branded condoms for the young people if they want to have it. And at the same time, we have anti-pimple creams, free of cost to the young people so that to attract them. And then, you know, some of the facilities have even gone further. They've constructed parks where our young people can play, the children can come and play, especially the younger adolescents. And then we have one community health center had gone further of making a fitness gym where the young people can come and use the gym, at the same time avail the services at the adolescent-friendly health clinics. So, extensive publicity, outreach program by adolescent counselors, RKSK films, those are all set. Posters and leaflets distribution for health facilities in schools and community halls. We have here, you can see our adolescent-friendly health clinics here with all the IEC materials, counseling films, then the library work. At the extreme left, above, we'll see the gym that is there and the basket of choices down. And then, yes, sir. Yes, no, we are not going to show the film. Then the simple and catchy IEC materials, which we'll see down in the poster stall. You can have a look at it, and if anyone wants to take samples, you're free to take them from the poster stall. Then quantifying the outcome, you know, the average adolescent participation in 16-17 is just 60. And after the intervention, just the 2 quarters, we have jumped to 170. These are, and then the average client per month for adolescent-friendly health clinic from 21 to 46 through these interventions, but this is happening only in all facilities because we have the PHCs way back from the, before they were known as ARSH clinics. But average clients per counselor per month, especially in the RKSK implementing districts, in the high priority districts, it jumped from 55 to 99. So I think we can see that there is some improvement in the footfall. Thank you very much. And here we have a very small snapshot about the activities. I would like to play that. How do we go it?
So Joy, can we have the next stage, please?
Okay. Thank you so much. Thank you.
Well, thank you so much for a beautiful presentation.
Thank you very much. Can we have the representative from Kerala? Yeah, please come over here. Like your time is running fast. Please come.
This is Dr. Amar. Dr. Amar, I'll request you to focus on things which you have done differently in Kerala from the other states and not the same.
Good evening, ladies and gentlemen. It gives me a lot of jitters to be here in front of such a distinguished panel here and a very esteemed audience. Kerala is a very, very special state. We are very literate, and I think in Kerala, e-literacy seems to be moving even more forward than the regular literacy. Our families are becoming smaller and smaller. It seems that the grandmas and grandpas are disappearing. People who can guide teenagers are disappearing. They're nowhere in the field. The out-of-school teenagers are also a very rare lot because all the children are in school, studies are at a premium. Everyone is all the time saying study, study, study. Recreation and games does not mean football or cricket. Recreation means looking at WhatsApp and looking at phones, Facebook pages, and enjoying what is coming, the jokes which come. So in that way, Kerala is a very special state, God's own country to the tourist, but an alarming scenario for the adolescents and the families who have teenagers. Keeping this in mind, we have wholeheartedly adopted the RKSK strategy that has been advocated by Government of India, and with the very effective mentoring by our national team here, Kera Saab and Dhiraja ma'am. The national team has been mentoring us so well. So our footfall of RKSK districts has been going up very fast. So we started with 2 districts. Now, one of the significant things I would like to highlight here is that the last picture, the entire state is now RKSK, going to be covered by RKSK. This has come about because we have been able to convince our government, our health secretary, our government, we have been able to convince them to give us state plan funding for adolescent-friendly health centers. So that way, launching of the adolescent-friendly peer educator service and RKSK model services we are going to do in the remaining 7 districts. For us, it's going to be a big landmark development. And we really see RKSK as a pill for every ill, because the students, the peer educator system that we see is, we feel, the best thing to deal with the friends. So we selected the necessary people from schools, 8th, 9th, and 11th standards, and we use the methods of convergence and piggybacking. The schools in Kerala have a lot of clubs running. Health clubs there are agriculture clubs, there are plant clubs, all sorts of clubs are running. In addition, we have got people like scouts and guides, the Red Cross people, a lot of people are there in the school. So we piggybacked on those established platforms so that we could run our services very effectively, and we were able to have convergence with these departments and these people. So they have been helping us in running the peer educator system already. Regarding training, we thought we would get the doctors to do the training, but unfortunately doctors have been busy with all the emerging disease outbreaks and communicable disease control and all that. So what we did is we tried to bank on the big field of health workers. Now those are people who were never counted to be teachers. They were all busy catching mosquitoes and going after the waste disposal and all that, but now we gave them a new status, and we find that they are thoroughly enjoying the status as teachers. We gave them the necessary training, and they become so motivated. We boosted their image and made them feel like good teachers. And we even send those health workers, health staff like health inspectors, junior public health nurses, we send them to other districts, inter-district experts. That term was given, and so they are feeling very motivated. And all that energy has been now transmitted to the peer educators they trained. It's a very joyful bunch of kids that they have trained up, and the training sessions were really fun to watch. And the children are really, they seem to have acquired nuclear energy or atomic energy, whatever. So the peer educators are really charged up in Kerala, in the districts that we have started the rollout. We even started calling them little doctors. Some of the districts have given them coats, white coats and all that. So that has given them tremendous self-respect. The feeling that, see, I'm a doctor, that sort of feeling is there. It gives them the authority, it gives them the emotional authority or the mental authority and the mental courage to go and talk to their friends, to lead them, to mentor them. And 3 tasks that we have put there in blue color. The buddy detection, early detection, because we have trained them on what to look out for. It's a sort of surveillance system inside the classroom, inside the school, inside the campus. Early detection, they will detect buddy detection. Then buddy health, because we have trained them in basics of adolescent health. So things like anemia, things like pimples, things like obesity, leanness, they will do the buddy health. And also things that they can't handle, they know the buddy referral. So they refer up to people, they know the linkages, who will help, where the counselors are, where the adolescent-friendly centers are located, where are the child protection units, so they will do the buddy referral. So buddy detection, buddy help, and buddy referral. These are the 3 tasks we have given them in the playing field of schools. Recently, we were able to induct them into the first battlefield. That is, Kerala has been doing the measles rubella vaccination campaign now. And we were able to deploy these trained RKSK peer educators in helping out, priming the children to come for vaccination, removing their fears, and post-vaccination engaging them in play games and activities so that the vaccination was taken as a joyful experience. So we were able to reduce the opposition to vaccination by the use of RKSK peer educators for MR campaign. So that is in the battlefield. Taking encouragement from all this, our peer educator numbers are rising steadily. 7,000 is our target now. We now have 7,000. We'll be steadily going up from this number upwards. Adolescent-friendly health centers. I keep on referring as centers rather than clinics. You might have noted that I'm avoiding the word clinics. It's my pet idea to avoid the word clinic because clinic is a threatening word, center is a friendly word. So I wish even in those 7 C's, we could change from clinic to centers. So the adolescent-friendly centers footprint also is steadily rising, as you can see. And 83 means the new districts which are taken up by state plan fund also will have adolescent-friendly health centers. Some additional supportive things which go along with this system to help the peer educators, to help the teenagers, is one of the telecounseling centers which we have. It's just like what we have talked about here. We have our own helpline called 1056 Disha. It is called Disha. It's a 24-hour system. Nothing new, but again, many states do have it. We also are running it very efficiently. Other innovative, significant things is one is that we are trying to rebrand the word counseling, because counseling is a very scary word for every family. The word means mental illness, the word means mental sickness, something wrong with your child, something wrong with your family. So we are trying to rebrand the word counseling as a center for ideas. Counseling means providing ideas for every normal teenager. It's not for the troubled teenagers, it's not for the mentally sick teenagers, it's not for the teenager with a suicidal tendency. Counseling is for every teenager. That's my idea. Counseling is for every teenager to overcome daily challenges, to overcome daily worries and fears. The Kudumbasri, the last word, if you can focus on the last word, Kudumbasri, menstrual hygiene program in Kerala. Now we have enlisted the support of a women's self-help group to provide napkins. So specifically we selected women's self-help group over big corporate companies because it is by the women, for the women, of the women. So it's that sort of approach. So they are now providing napkins to run the menstrual hygiene program, because Government of India has now stopped supplying napkins. We are trying to become self-sufficient. It's our first foray into that area. Radio help, we have a radio station, we have a radio studio to produce programs, and the bulk of those programs are on adolescent health, and we are broadcasting daily through 9 stations of All India Radio all over the state. Very short, snappy programs of 15 minutes on things like friendships, love affairs, scoring marks, pimples and whatnot. Everything that interests an adolescent comes on the radio for 15 minutes every day. It's not only the teenagers who are listening, we find that a lot of parents are listening to it. So that way, this is also a supportive system. Forward, we are going forward. Training is going to be a big challenge because we all feel that 7-day training for or 6-day training for a peer educator is not enough. They don't acquire the skills to converse and hold meetings and all that. So we intend to have continuous mentoring for these people to keep them under our wing continuously and really make them capable of becoming social leaders. And the Satya adolescent relationship is something that we are going to foster. We do need to make it a sustained, long-lasting relationship. And finally, let every adolescent in Kerala and maybe India have a friend, philosopher, and guide among their own buddies. So that's our aim. Thank you very much. This thank you comes right from the thank you comes right from the so many teenagers of the state. Thank you very much.
Thank you so much. This was really brilliant. I'd like to invite now my co-chair, Chandramouli from WHO, to give some of his remarks, because he said he's running for another session. So before, Monica, you'll have to wait a little bit. Yeah, please.
Thank you, ma'am. I just have 3 points to make. It's been a fascinating 1 hour listening to these sessions. First is, clearly there's a strong policy environment and strong political commitment for this program. The second is, there's an ambitious program building on the previous ARSH program. And what was wonderful to hear from Sushma Dureja's presentation is there's the openness to learn and to develop with mid-course corrections to slightly change the way forward. And what was particularly interesting is these 4 wonderful state examples. Amit Shukla talked about building on the work already done. Dilip Kumar and Smita Shinde talked about using e-learning to reduce the training approaches in the past. Joy Lugwe and Amer Fetley talked about using different terms and not calling them clinics, and the buddy program that I've heard you present before. Clearly, a good policy context, a program which is ambitious and open to learning and fascinating innovations. Clearly, state-level people empowered to learn and to grow as they do so, and given the space to learn. So for me, this is fascinating, both as a WHO professional and as an Indian. What I'd like to see much more is, as you move forward, careful documentation, careful monitoring, careful evaluation, so that, like you said, ma'am, the change in course is based on evidence generated from the field. So I'd like to thank you all very much. And with apologies, I have to run to moderate another session. Thank you.
Thank you so much, Andhra. Monica, I'll invite you to just quickly share some of your findings, maybe some 3 or 4 critical points that have emerged from your evaluation in the interest of time.
Thank you very much, ma'am. This is a joint presentation. This is a study we are doing to evaluate the peer educator intervention. Since yesterday, we have been hearing RKSK is the most comprehensive and a unique program, and also hearing that evaluation is very important, and Chandra also just mentioned evaluating and getting mid-course correction. So this is a step in that direction. And this is evaluation we are doing as implementation science research. The evidence on peer education intervention is that there is effectiveness, but also some research has pointed that a coordinated and complementary approach is required. Thus, what we are doing is we are going to study under this particular evaluation context. What are the contextual factors influencing implementation of the PE intervention, the Satya program? Mechanisms through which it exerts its effect. So context has an influence on intervention, and intervention, again, has an influence on the context. So understanding this context, mechanisms, and the whole process of implementation as to what is working for whom in what context. Impact on adolescent health outcomes and their equitable coverage, as well as we are looking at cost effectiveness as well, so that we are able to give a model when we are giving this recommendation to the government on what needs to be scaled up. There are components which may be more effective as compared to others, and we should be able to give that guidance with this implementation science research, not only to India, but also adding to the global literature on PE intervention. It is around 3.5 years of study period being done by PHFI, London School of Hygiene and Tropical Medicine, with Ministry of Health and Family Welfare. And the 2 states that have been selected is Madhya Pradesh and Kerala, because we are having 2 settings, as you heard. Peer education in a community setting, with MP being the state, and 2 districts identified are Chhatarpur and Dindori, the rural districts. And Kerala is a school model. So we have an excellent opportunity here to compare a community versus school intervention and looking at context and mechanisms in these 2 contexts. Quickly, the research aims are, as I said, we are going to look at the process. We have been talking about the clinics, footfall in the clinics, which are the ultimate outcomes, but the process is also very important to understand. We are looking at causal mechanisms and implementation, and this will be a mixed methods research, so we have both surveys as well as qualitative techniques. And we are looking not only the impact on adolescents, impact on peer educators, but also on the parents. We are going to see whether attitude and communication skills of parents have changed, impact on PE in terms of their leadership and communication skills, and definitely the adolescent-friendly health clinics. At the scale up, we are looking at horizontal and vertical scaling up. Okay. The whole operational framework of RKSK has been converted into a logic model. So everything you find in various places have been compiled into this logic model, which will help guide our intervention. and also the whole evaluation. This whole logic model will guide our evaluation. Inputs that we are looking at, I'll not get into a lot of detail because we are short of time, but as you all know, we have laid a pathway. Yeah.
You will have to, if you are
I
still
will-
in the process, and I think we really look forward to the results, but if there's
Yeah.
anything critical that you would like to
Just,
point out about the
a
importance of this research?
Because the whole
do that.
intent was that we are able to show the various evaluation techniques that we are going to be using, FGDs, IDIs, documentary analysis, and also for implementation and mechanisms, we have routine data, survey, observations. This is the most critical part which we wanted a discussion and states wanted to understand how we are evaluating. So we have 3 cycles. We are doing a peer survey, peer educator survey, adolescent survey before the training. Then we let 1 cycle pass, do another midterm evaluation of both, including parents. And the next year, we do an end line. So this is the kind of model we are following, using 2 districts and having CHCs, having intervention and control arms. And within exposures and outcomes, this is just a quick shot of what outcomes we are looking in adolescents and parents, peer educators, and adolescent-friendly health clinics. Just the last slide, saying that the study will provide research evidence needed to effect the real and practical change to improve the implementation of the PE intervention, but looking under the broader umbrella of RKSK, so looking at other components as well. And this will be providing us a very important equitable solution for sustainability, how peer educator component and intervention can be sustained. And as I said, we are looking to add to the global evidence as well as improve whatever is going on in India with this evidence. Thank you very much.
Thank you so much, Monica. Before I request my co-chair, Dr. Venkat, to speak, I would invite the delegates if they have any questions, especially from our states who just made brilliant presentations about their work. So the floor is open in case there are any questions that you would like to ask. Good.
May I begin?
Please carry on.
Thank you for that very interesting presentation of this rather complex program. I'm curious to understand why you chose not to pay the peer educators who are a crucial part of your intervention. One of the things that we know in working with people in disadvantaged situations is that it's really important to value their contributions not only with laud and pomp and circumstance, but also to remunerate them, and in particular with adolescents who may otherwise have other priorities, to actually recognize their work through remuneration. And that doesn't necessarily mean remunerating them as much as you would a counselor, but that there should be some remuneration to recognize what seems to be a pivotal contribution to your program.
I'll request Dr. Dureja to take this question.
They are not being paid in cash, but they are having non-monetary incentive to the tune of 50 rupees per month. And the states are at liberty to convert it into a magazine subscription or recharging of mobile or any other form that is suitable for the peer educator.
I think the entire concept is based on voluntarism. So this is just to keep them motivated. There are some non-monetary incentives which are part of the initiative. There's a question from that end at the back.
Yeah, so
Can you reach the mic? Yeah.
Greetings to the panel. So my question was about the role of the accredited social worker, the ASHAs in the communities. Some of the states talked about the struggles they've had with when it comes to using ASHAs in the system. So my question is that how is it that we're addressing the concerns when it comes to ASHAs? They're finding themselves overburdened already by other parallel systems such as the Anganwadis or the community health work, in addition to also handle work with adolescents. How are we addressing their concerns as a part of the frontline health worker?
Ashas are involved in only certain activities. They facilitate the selection of peer educators, one thing. Then during the Adolescent Health Day, which is a quarterly activity in village, they again help the peer educator and other functionaries in arranging the adolescent health activities. That is the main contribution. Plus, because they are working in the same community, they orient the peer educator about the families, the presence of peer adolescents in the households, that's all. They are no other way assisting the peer educator. And they are duly incentivized for both these activities.
That's a very valid point that you had asked, just adding on to what Dr. Dureja said. What we have been contemplating in the program is that how do we engage the civil society organizations better in this entire program, because we do realize that the health workers are already overburdened with the existing responsibilities, and therefore we want to engage better with the CSOs. The RKSK framework does provide for engaging and involving NGOs and CSOs, but I think the challenge is to work alongside with our states and to give them the confidence and give them the required capacity to be able to engage with the NGOs, and that's something we are working on, and that's something I wanted to speak about in the way forward. Okay, we have, yeah, please.
I have some questions and suggestions. Is the government here, Ministry of Health, thinking about any program for the out of the school children? The second is this iron folic acid thing is not carried out and it is not happening in the private schools. It is intentionally omitted or they are not accepting it. Deworming and iron folic acid, the private schools, they don't have. And
You have one more question?
yeah, some suggestions. This is such a massive program, wonderful program, so fascinating. Government is doing so much for the adolescents. As per the law of the land, this, these health workers are aware of this under the POCSO Act, that if they come across any disclosures, they have to mandatorily report. And for the healthy sexual development, are they aware of this law of the land? The age of consent for sex is up to 18, not. It has been increased from 16 to 18.
Are you talking of the new Supreme Court judgment also, which has recently come?
Of course, yeah.
Okay. Can we have one more question? We'll take the two together. There was one more question on that side. Yeah.
Hello, myself Dr. Shobha from Seva Rural Jhagadia. I'm just concerned, I reminded the CHV scheme, Community Health Volunteer Scheme, and it was voluntary. Then we started 50 rupees per month, and then it was not succeeded. But with ASHAs, like frontline workers, with the incentive schemes, we got good success. And peer educators, I think they have more scope to work, not only for WIFS, or they can work as for de-addiction and personal hygiene, lot of issues they can work. So I think some type of incentive they should be given in regularly, otherwise, or just only voluntary work, I'm afraid how much it can be sustained. Thank you.
Dr. Khera, would you like to take some of these?
No, I would like to respond to two important points. Now, one of the point which has been talked about is the PE program. I mean, identifying the peers in the community and then getting a kind of a volunteer work, And we also finding there is a lot of challenge in keeping them, retaining them, training them, because they keep on changing. The different cohorts of the peer educators, they keep coming, keep going, and particularly addressing those complex issues. So that's why Madam also made a reference that we are trying to kind of restructure the program in such a fashion that the so-called the Ps who are there in the field, we are going to get this implemented in a project mode. That means maybe we engage civil society, we may engage academic institutions, or any kind of a structure in a project mode, where there is a system of regular mentoring and monitoring will also happen, so that we in the field get some kind of a impact as well. So that was number one. And then the second point which has been talked about was in terms of huge problem of anemia. I think we have been talking about it since yesterday, and that's why the Government of India is also coming up with a strategy which is called as the anemia-free strategy, where iron folic acid is going to be a life cycle approach. That means it is not only adolescent, even the pregnant woman, lactating woman, even the children, and even the women of the reproductive age groups will also be provided supplementation of iron folic acid. And Madam, I think you raised the point regarding the private schools. Certainly I think the private school also will be taken into consideration. But at this point of time, we find that the WIFS program, which is running quite well, we have been able to reach our coverage to the tune of 30%. But maybe in the phase 2, you will find we'll be reaching a private school as well. Out of school also.
Out of school are all covered.
The peer education program actually is largely for out of school children. There are activities in the school also, but there are activities out of school. Plus you have the Adolescent Health Day. So the RKSK framework and program certainly provides for both out of school as well as in school children. I would now like to invite my co-chair Dr. Venkatesh for some final remarks before we wind up the session.
Thank you. I think a lot has been talked, and state presented their innovations. I would like just to reflect just on two things. One that has not been mentioned, I think it's the biggest commitment of the government, which puts in $55 million for the international participants, is $55 million a year into this program. I think that's the biggest commitment. Many countries come up with strategies, but not backed with financial envelopes. I think that's a very positive thing. The other thing, I just wanted to share that concerns on peace, incentives for peace, I think there could be a discussion later, even with colleagues, let's say from YP Foundation and several others. There is the need to engage the peer educators, peer facilitators, satyas in this case, in interesting activities. The notion of getting money still fortunately hasn't corrupted the young people in the villages, and that's also been UNFPA's experience of working with the Yuva Kendras across the country for several years. Thank you, thanks to the ministry for giving us this opportunity to be here and also be associated with this program in many states. Thank you, madam.
So now I think, if there are no more questions, I'll request Madam to give the concluding remarks.
I think morning it was very encouraging to hear Gigi speak about 4 points for adolescent health: action, 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 action. And it was, I think, really heartening to hear from our 4 states. So 4 points and 4 states, extremely diverse states, and the action on the ground, which I'm sure the delegates here would have found extremely interesting. India stands very strong at a huge population of 1.2 billion, and this strength comes from our adolescents, the huge adolescents, which we are very hopeful will help us realize the demographic dividend. Today we've had the excellent opportunity of listening to diverse states, from Uttarakhand, which is our hill state in the north, as to how they're running an extremely comprehensive program with clinics and how they are working with communities, with peer educators, with the helpline, and how this link between the community and the clinic has really spurred the program and increased the footfalls also in the centers of the clinics. Madhya Pradesh, extremely interesting presentation on how they overcome the challenges that they initially faced in the adolescent health program, and how the program was made completely friendly towards the adolescents, and how they were making this program more and more sustainable with the shadow peer educators, the use of technology, whether it is the mobile app, the use of interesting mediums like comics, e-learning that they're using, extremely interesting learnings through the program and how the program has been evolving. Meghalaya, again, interesting learnings in terms of how the adolescent counselors are making a difference, the involvement of brand ambassadors, how the adolescent health days are having a lot of fun activities, and how their clinics are really friendly and vibrant places to attract the adolescents to come there, spend time, and talk to the counselors and to each other. Kerala, again, another very different example from our country, highly literate state with a completely different composition of population, how they're using schools as a very active platform because all the children there are in schools, how the PHN is being involved, the little doctors, and very encouraging progress on vaccination, how the peer educators have really been involved in improving vaccination in Kerala. Your work on the menstrual hygiene also supported from the state, very, very, we really appreciate that work that you're doing. So I think from India, as we can see, and from our states, there are huge learnings, and through this Congress and its subsequent chapters, which will happen in the coming years, we hope that the learnings from India would also be useful for other countries in the region and around the globe. While we get a lot of learnings through this Congress from other countries, but what India has achieved through RKSK in the last 3 to 4 years does offer very important learning that our states have got, which we would like the other states and other countries to also look at. In terms of way forward, we are, yes, looking at a more intensive integrated activity at the school level, CSO involvement, which Dr. Khera talked about, anemia-free India. We have a huge problem of anemia. Despite making a lot of progress, which NFHS has shown, anemia still among adolescents and among all age groups is very, very high in our country, and that's a campaign and a program, a holistic program that we are working on currently. And along with SRH, mental health, NCDs, and preventive promotive work, especially through the school platform that we are looking forward to and working on. Implementation research would be extremely important to give us ideas for any mid-course correction that we may require. I would be failing in my duty if I did not thank the YP Foundation and PMNCH for preparing the advocacy toolkit, which was released today. And we hope that this would really help adolescents in the country to engage more and more at the policy level in designing as well as in helping us implement these programs better. So with this, I'd like to thank all of you for being here and participating in the India section of the Congress here. And I wish you all a very pleasant stay, and I hope you have time to enjoy the sights of Delhi. This is a wonderful time of the year to be in Delhi, so enjoy the sights and the lovely food that's available in Delhi. Thank you.
Thank you very much, all of you, and I'd also like to thank the chairperson and the co-chairperson for organizing this important symposium.